We're going to start now, gang. Are you ready?
Yep.
Okay, so I'm going to share my screen. And I'm going to enable everything, start here, and share, and do view slideshow. Okay, well, everybody, welcome back. And we're going to begin today with Q&A. We got a few questions in, so don't forget, when you send in questions, they'll be answered. But as you'll see with my answers for these questions, whatever you're pondering about gets me to ponder about how I can use that to spin off more critical information for you to know. So we're going to be talking today about Q&A, and then because of what happened in my life, so I let that kind of drive what we're going to share, we're going to talk about an endometriosis protocol that's pretty effective. So I was just traveling too. We have Charisse that's traveling. Here's me at my first layer. Here's me sitting in the cabin putting colloidal silver in my nose. And I thought I would also just share with you what I had to go through inside the cabin in the airplane. Huge dog behind me whining the whole time. Can you hear the doggy? So I have goggles, a mask, several masks, and a doggy. So that's what I just wanted to show you. That was like, oh my God. So one of the questions came from someone. I have a patient who has symptomatic gallstones who is currently on tamoxifen. You know, tamoxifen is one of the standard treatments, and it's supposed to be an anti-estrogen, but you should know that most of the literature shows that within 5 years of going on tamoxifen, 70% of women have 4 to 5 elevated levels of estrogen. So we think that it's not just, it doesn't work only with an underlying mechanism as being an estrogen blocker, but by other portals. But the question was, I have a woman who has symptomatic gallstones. So she has pain, most likely in her right shoulder, going down her arm after fatty meals, who's currently on tamoxifen after chemo and double mastectomy. She has elevated triglycerides due to tamoxifen. So this physician suggested bile acids, the D-limonene, to help clear cholesterol due to increased estrogen in the liver and gallbladder, which we're going to talk about. Is that really what tamoxifen does? Not necessarily so, related to tamoxifen. And her cancer doctor said, nope, nope, nope. This was contraindicated and don't take these supplements. So this doctor said, I wasn't aware of any contraindications. I thought you might know, why would this be the case? So first of all, I looked up D-limonene, and it turns out that it is a mild liver toxicant. It's mild, but you're going to find out that tamoxifen is very stressful on the liver. There's different studies that show that 1/3 of women who take tamoxifen within a few years get fatty liver, and some don't ever get fatty liver, but there is a potential to get liver injury on tamoxifen, and we're going to talk about it. So it makes sense not to be on D-limonene because it is a mild liver toxicant. The bile acids, I'm going to say nay to that, but I think that most oncologists really say that most nutraceuticals are contraindicated because they don't understand them. So it's a standard line to cover their safety and to cover themselves with their malpractice, because a lot of nutraceuticals, for example, melatonin, help chemo work better, act as aromatase inhibitors and estrogen modulators, and they'll often say go off of that because they don't understand the literature. So it is a standard line, but I'm going to take umbrage at why you recommended bile acids, and we'll go into that in just a minute. So tamoxifen is a selective estrogen receptor modulator. You all know that, but I don't know if you know that once a woman is on it, most of her lipid particles go down. So the LDL goes down, the total cholesterol goes down, low density lipoproteins go down, but triglycerides go up. And that is a common lipid pattern over several years of a woman being on tamoxifen. Here was a meta-analysis of 5 studies with over 200 participants showing this. Most lipids go down and triglycerides tend to go up. Now, bile is an emulsifier. It's made in the liver, stored in the gallbladder, and we release it to absorb fat-soluble vitamins and also other types of fats like omega-3 fatty acids like DHA and EPA. But bile, if it's inappropriately released, can also be a procarcinogen. There's quite a number of studies trying to take a look at women who've had their gallbladder removed, because once your gallbladder is removed, you have a drip, drip, drip of bile all the time because you don't have a piggy bank of bile anymore. Some studies say that women who have chronic release of bile post gallbladder removal have an increased incidence of colorectal cancer because it's irritating the lining of the gut. Other studies have not been able to show that, probably because there's an individual response as to who can clear up the inflammation caused by bile when it's not needed. So bile isn't really something that you would give to lower triglycerides. And in a person who's already had a history of cancer, without knowing that they don't have steatocrit or extra fat in their stool, why would you give bile? I mean, we usually give ox bile replacement when on a GI map we see elevated fat, the steatocrit is elevated, or we have a lot of fat-soluble insufficiency symptoms. For example, someone who's taking 5 to 10,000 IUs of vitamin D and it never goes above 30, that gives you an idea that they're not solubilizing their fat-soluble vitamins. And you'd really then want to take a deep dive into all their fat-soluble vitamins, basically A, K, and D. And by the way, I wrote this huge treatise on K, which is in our notes this week, because I think vitamin K is a pretty confusing and mysterious vitamin. It's named vitamin K because a dentist in Germany discovered it, and the word for vitamin K in German begins with a K for coagulation factor. So he ended up taking that German word and making it a vitamin K, but it has so many subtypes. So if you want to learn more about vitamin K, I did a big write-up this week. If I was going to want to lower triglycerides in a woman on tamoxifen, fish oils are the number one thing you want to do, and it's all about dosage. You want to give plenty of fish oils. Plus, fish oils are modulators. Fish oils are like natural selective estrogen receptor modulators. They act in a little bit. They don't block estrogen receptors, but they act as estrogen receptor modulators. Artichokes, like artichoke paste by a company called Mantova, a teaspoon of artichoke paste twice a day is fabulous for lowering triglycerides and having better hepatic processing of hormones. Colorful berries, silymarin, milk thistle, a little tiny bit of niacinamide, not too much, but I don't know why you would give bile. So if you're on here, Karen, later when we go on a little further, you can let me know why you were suggesting we would give bile. But to lower those triglycerides, I think this would be a protocol of what you would use. Now, long-term therapy with tamoxifen has been linked to a whole bunch of liver injury. This is clearly in the literature, doesn't happen to everyone. As I just said before, some women have, a third of women develop fatty liver during tamoxifen therapy. Now, what's really interesting is estrogen has everything to do with the caretaking of the liver, and tamoxifen blocks the action of estrogen in the liver, and so there's no more protection. For example, we now know that sleep apnea is huge in pediatrics, in young kids. There's an epidemic of sleep apnea in young kids, and then they're getting fatty liver from it. Why does sleep apnea cause fatty liver? Well, sleep apnea is so stressful on the body, and it elevates cortisol, then cortisol competitively sits on estrogen receptors, and even though there's estrogen around, it can't signal the basic cell, the parenchyma of liver, the hepatocyte, and protect it. So this was proven by functional MRIs. So what's the hepatotoxicity of tamoxifen? And I'm not going to go into it too deeply because you can read these slides, but most of the liver injury, if it's going to happen, will happen in the first 6 months. It could mostly happen without any symptoms, or they can get gallbladder pain. They can get some elevation of liver enzymes. They can get some dermatologic features and sometimes antibodies. It usually is self-limited. There is conflict about whether tamoxifen is so damaging to the liver, does it cause liver cancer down the road? So in one large retrospective looking back at a large group of women, there was no increased incidence of liver cancer, but other studies, several other studies, show a 6-fold increase in liver cancer among women taking tamoxifen for more than 2 years. So I really like high-dose melatonin. I'm not a big fan of tamoxifen, but if a woman comes into you on tamoxifen or has been on tamoxifen, she needs liver support. My editor had breast cancer, did everything we wanted, and she suggested to do, but decided to take tamoxifen. And she ended up getting fatty liver and ended up getting a backup of her lower arterial venous system and venous disease. And now she's wishing she never took it. So I don't know if we would have done, I didn't know this about tamoxifen, that all patients on it should have a deep dive with protection of some of the things we just mentioned, and we'll mention a few other things. The fatty liver can be with symptoms or without symptoms. The other thing that can happen is some women develop worse than fatty liver. The next level is fibrosis. So liver biopsy may demonstrate steatohepatitis, so they've got fat entering in the liver cells, but some women get fibrosis. Now, all fibrosis is driven by transforming growth factor beta 1 or galectin-3. There are two cytokines that drive all fibrosis. If anyone's got fibrosis anywhere in the body, it's because of these molecules. So the other thing that all women on tamoxifen should be tested for are these two potential molecules of what I call mass destruction. If they're within normal range, forget it. It's okay. But if they're elevated, you're going to want to protect your liver from fibrosis. So we give high dose taurine, 2,000 milligrams, 3 times a day to bring down transforming growth factor beta 1 if it's elevated. Taurine, the amino acid, 2,000 milligrams 3 times a day, and make sure the vitamin D is about between 50 and 70. And the other way is galectin-3, which we normalize if it's elevated, only if it's above 22. And the ranges for TGF beta 1 are all over the map depending on the labs. Galectin-3, if it's elevated, you use modified citrus pectin. Of course, most patients with cancer, you already want them to be on modified citrus pectin because galectin-3 is a cytokine that helps tumor cells hold together to form a solid tumor. But so all women on tamoxifen should be tested. And I, of course, think these are some of the molecules of mass destruction that I've been teasing apart over the last few years. Maybe we should do a show sometime on all those molecules if you want. But that's what I would do. I would run this on all women who have a history of being on tamoxifen or are presently on tamoxifen. And of course, because now you see the liver injury potential of tamoxifen, you wouldn't want people drinking alcohol. And you'd want them to be really careful about acetaminophen and NSAIDs, just moderation, because of now you know this potential issue with it, which no one ever mentions to you when you work with your oncologist. They think the mechanisms are several possible folds. So one acute form of liver injury is attributable to an idiosyncratic. So as the tamoxifen is metabolized, the metabolites can ding the liver cells rather than an estrogenic effect. So some of the downstream metabolites as the body processes tamoxifen appear to be liver damaging or injuring. The other initiation of fatty liver is most likely due to its anti-estrogen effect. She thought a pro-estrogen effect. No, it blocks estrogen at the liver. Estrogen is a protector of the liver. And probably that also depends too. Does the woman have sleep apnea? Does she eat junk food and high fructose corn syrup and not exercise? If she's on tamoxifen and has all those lifestyle issues because no one at the oncology office talks to her about it, she might be more prone to have fat buildup in the liver or liver injury. And she might also just have the genes that make her more prone to an issue if she's on an estrogen blocker. So tamoxifen blocks aromatase enzymes in the liver, and it blocks the protective action of estrogen on the basic cell of the liver, which is the hepatocyte. We call parenchyma, local tissue is called parenchyma. Liver is, the word for that is hepatic, so hepatic parenchyma. Most of you know that, but just in case there's some patients on here that don't know that. So what's the estrogen liver connection? And this is so important. More people tend to get fatty liver as they get older because they have less hormones, because estrogen is protective of the liver. It's one reason men need estrogen too, because estrogen protects the liver cell, and it also protects even the prostate cell and the heart cell. It's a protector of lots of cells, but in this case, we're talking about the liver. This was a really interesting study. The liver has a tremendous ability to regenerate. We all know this. You cut out part of the liver, it's one of the organs that can grow itself back. That's called rejuvenative. It has this incredible rejuvenative ability for mitotic activity to regrow itself. So in one study, they removed 70% of the liver. Of course, this is in animal studies, and the estrogen levels in the blood were elevated, and the number of estrogen receptors in the remaining part of the liver were increased, and there was active estrogen signaling, because estrogen is protective and it's part of the rejuvenation and the ability of the liver to keep rejuvenizing himself. But then when they gave tamoxifen to the animals, it was an estrogen antagonist, and this inhibited, even though there was estrogen on board, after they removed part of the liver in these animals and tamoxifen was given, they couldn't have rejuvenation of the hepatocytes because the tamoxifen blocked the ability of estrogen to drive the rejuvenation of the liver. So the ability of the liver to regrow itself is estrogen dependent. And as we age, if a woman doesn't have any estrogen on board, she becomes more and more prone to having fatty liver and liver injury. And then if she's older and heavier and then on tamoxifen, which makes them older and heavier because it accelerates aging, then she has even more of that. So you definitely want to have a lot of, you want to follow their molecules of mass destruction, transforming growth factor beta 1 and galectin 3, and you want to have fish oil, you want to have liver supplements, you want to eat a diet that's very low in processed sugars and high fructose corn syrup, and does all the things that are rejuvenative, and probably even some liver glandulars. Biotics have some of the best glandulars of any company right now, because they get them from organic neonatal lamb from New Zealand. And I went over to the manufacturing company and I watched how they processed everything. And it was like being in an MD Anderson surgical theater. So I felt really good about it. This is just some more information about the role of estrogen and tamoxifen, but I'm going to want to probably go on a little bit because we're at 12:17. But it's so interesting that estrogen boosts DNA growth and the number of cells that rejuvenate, and tamoxifen blocks it. So you have to focus on liver health with somebody who's on tamoxifen. Another question that somebody asked, I know Dr. Berkson does urine testing with her patients. If she sees that, so first you have your parent estrogens, and then in the liver, you add oxygen and hydrogen to make catechoestrogens, which are the 2, the 4, the 16 series. So she's talking about catechoestrogens. If she sees that estrogen, testosterone, cortisol metabolites like 4-hydroxy estrogen metabolites are high, what does she suggest to help in that process if these women are to take estrogen or testosterone therapy? Well, resveratrol is actually the doctor that first understood epigenetics first looked at the positive effect of wine and polyphenolic compounds like resveratrol on our genes, and especially how we process estrogen. And he said that he did quite a number of studies on resveratrol. So I usually give 400 to 800 milligrams of resveratrol a day. I run usually a serum iodine. I don't like the urine iodine because I don't feel like it's iodine that is being processed and used by the body. I think some of it is being rinsed out of the body. And I like the serum iodine level to be about 90 at the upper end. And I have a favorite liver support that I really learned from some patients. One of them, a pharmacist who then became a full-on functional doctor, said that this has changed a lot of her patients' lives in her own life. And it's called, by NF Factors, which is a naturopathic doctor's line, Liver SAP. And it's got a lot of the herbs in a synergistic formula that really help process, because all of these metabolites are made in the liver. So this is my 3 musketeers for helping estrogen metabolites be more improved. With testosterone metabolites, the iodine is very helpful with that. And the other thing that's very helpful with testosterone metabolites is quercetin to help process those metabolites. So it depends on which hormone you're talking about. Another question someone sent in is, what is your opinion on biomimetic hormone replacement therapy, or also known as rhythmic HRT? This is the Wiley protocol. And I don't really know much about the Panacea protocol. This mimics the natural levels in cycle bar hormones, and a woman continues to get her period for as long as she cares to have it and will never go through menopause. So I've been in practice, as you know, a really, really long time, and you get to hang out and know the people who put forth different theories. And I had dinner one evening, one painful, long, arduous evening. It was a painful evening with Wiley. And she's manic. She talked for 4 hours straight. I couldn't get a word in edgewise. She has a good heart, but she's kind of crazy. And I don't do well with really crazy people. She's not a clinician. She's a scientist. She's very smart. But I have a patient right now that a doctor sent me yesterday that's on the Wiley method, and we figured out how much of progesterone she's getting based on this rhythmic HRT. And I called the pharmacist, and this woman is getting from 1,400 milligrams to 2,600 milligrams of progesterone. And she's not doing very well, because sometimes with hormones, when you give too much, you down-regulate the receptor. And there's periods within the Wiley protocol where the hormone levels of what they're giving are extremely high. Some women love being on the Wiley protocol. Myself, I don't want to menstruate. If I'm done with menopause, I want to be done with menopause. And I worked with a very famous, he ran, his name, he was at Charity Hospital. He was a gynecologist that had the laser clinic of Metairie, and I'll think of his name in a few minutes. And he and I used to talk about gynecology and on. We would have these amazing conversations. I checked in on him just a little bit ago. He really retired after Katrina. And he would say, every time you menstruate, somebody's mic is really loud, so we have to mute you for a little bit. Somebody's mic is loud, so please mute everybody for a moment. Sorry about that. And he would say, every time you menstruate, there's more damage to cells, there's more mitosis, there's more growth factors, and there's more chance for cancer and adverse tissue consequences downstream. So it's better to have acquiescence, in my opinion, and not be menstruating every month than it is to be menstruating. And I think the person who created this protocol is a little unhinged. So, and I have now had a few women on this protocol who've gone on to get cancer, but I've had some women who feel so good on this protocol, they don't want to stop, the ones who didn't get cancer. So it's all over the map. I'm not comfortable about it at all, and for multiple reasons. And I really, if someone's got a theory, I don't want them to have a huge amount of ego, because then I don't know if I trust their data. And I want to get a sense of groundedness. I want to get a sense of study and replication. And I don't have that with this, so I'm not a big fan of this. Anyway, why is it that we replace low, and this is the last question, I think, and then we're going on, and we'll see if we have any questions on this before we go on to our next endometriosis part of the talk. And why is it that we replace low levels of progesterone, testosterone, and other hormones, but not estradiol? I don't know if that's really true. I don't know if you're saying this, and you'll see with the patient. I'm going to be talking to you about an 18-year-old patient very soon that had endometriosis and PCOS, and we end up giving her a little bit of estrogen. So we're seeing more and more young women have levels of hormones like menopausal women, not even perimenopausal, but menopausal women. But there is some, like Dr. Wright, my mentor, will not give hormones unless a woman is menopausal. He'll give vitamin A and boron. High dose vitamin A and higher dose boron really kind of jumpstart your body a little bit in some women to using your own estrogen. But now we're seeing that young girls, they don't even respond. And that's what you'll see with this one patient. We tried vitamin A and boron, and she didn't get anywhere till we gave her a tiny bit. So I'm going to walk you through that patient. So this is not necessarily true in all clinics, but it is, of course, the standard of care. But if you recall, I've mentioned to you that Harvard Center for Pediatrics didn't publish yet in peer review, but presented a study on 24 young women who had anxiety, depression, and body dysphoria. And some of them were heavy athletes, so they had very little body fat, so they had amenorrhea. But some of them weren't that thin. There were 24 from 14 years old to 20 years old. And they gave them an estrase patch for a year, similar dose for a menopausal woman. And at the end of that year, what was interesting with the dialogue from the researchers that did this out of Harvard was that most of the young girls didn't want to go off the patch. They felt so much better. They had less body dysphoria, less depression, less anxiety, because hormones are calming and they calm the neurotransmitters in the brain and they relax the entire amygdala and hippocampus areas. They really are very brain. That's why my last book was called Sexy Brain, because sex, steroid hormones rule the brain. So I don't think this is totally true. And I think we're now going to start seeing, if Harvard's going to do it, pretty soon we're going to see this entering more mainstream, but outside of mainstream, more functional docs are doing it. You know, I wrote an article, a blog, if you look in our Facebook group, on what Medscape said yesterday about thyroid. They said all cases should be individualized, and desiccated thyroid was just as good as Synthroid and levothyroxine. It's starting to change. It's starting to go to what the functional docs have been saying for several decades in the trenches. So I don't really think this reflects most functional doctors, but some, like Dr. Wright. But Dr. Wright also has been in practice for 50 years. He asked me to go up there and run the women's hormones, but I don't like that weather. But he mainly does men's hormones. He really has the other naturopaths in the clinic do women. He doesn't like to do female hormones. A lot of men have a difficult time because women are so difficult and they want the simpler patient. So I don't know if he's saying he'll only give it because he's really not treating that many women anymore for about 20 years now, even though he's credited with being the father of bioidentical hormones. So instead, doctors want to replace the estradiol when a woman has such low levels. You know, I don't think that's really true, but that might be the way a lot of gynecologists feel. So I agree with that it might be standard of care, but that standard of care, it's moving over. It's moving over. Would it not make sense to address depleting estrogen even when a woman still has a cycle? Well, in some cases, yes. You just don't want to turn it off. That's why we first take a look at some other interventions. If a woman has premature ovarian failure, there's a study where they gave 2 milligrams of oral estriol to 12 women, and in 10 days, all 12 women started to menstruate. So they gave estrogen to women in their 30s that were going into early menopause, and it rebooted that brain hormone crosstalk in 10 days in 12 out of 12 people. If you want, we can put that abstract up for you if you're interested in it. So there's times to use hormones that are not in the estrogen window, but that gynecologist from Harvard who wrote the book called Estrogen Window is an arrogant son of a bee. I interviewed him on my show and I didn't publish that show. He was very down on bioidentical hormones. He was very arrogant. He hardly let me get a word in edgewise. He said, it's only the estrogen window. And when I worked at Tulane, people have respect for individuality, and the estrogen window is morphing. But he was like, he invented this term, but he didn't really. And this is only when a woman should give it the first 10 years of her menopause. That's the estrogen window, from menopause to 10 years. And you can't get it after that. And he had a study that he claimed was a study that showed that bioidentical hormones were terrible. And I didn't know that study. So my blood pressure rose like crazy. And as soon as I was dripping with sweat, he was so arrogant and nasty to me. And when he finally stopped talking and I stopped the recording, I ran and looked up that study. And it wasn't a study. It was a survey sent out to gynecologists, many of them who work for AstraZeneca and for Wyeth and so forth, and they have conflict of interest. They speak for them, and they were just asked their opinion about bioidentical hormones. And here this guy was touting it as a study. So there's so much out there that's biased, arrogant, inaccurate, but you wouldn't know it unless you know all what's going on, which is why we have this kind of chit-chatty way to share all this. If you think this is helpful, please let me know. Put it in the chat if you think this kind of conversation is helpful. So let's, tell me if you have, I'm gonna get out of here for 1 second and see if we have any questions in the chat room. Forgive me, I'm in the airport. I don't think we do. What type of liver support? Well, I put that in there. I love that NAD liver SAP. That's one of my favorite liver supports now. And milk thistle, but lots of milk thistle. Standard Process has a great product called LivCo, which is a mixture of milk thistle along with rosmaric acid, because rosemary is very liver protective. But when someone is taking a drug that's that assaulting, you want high dosages. You don't want little moderate doses like 80 milligrams twice a day. You're going to want a few hundred milligrams twice a day. And the diet, of course, is also important too. I guess there's no other questions, so I'm going to go back. Is there any other questions? And if not, I will go back and screen share and make sure all this is on. Go back here and screen share. So this is a talk that I wanted to give at PCCA a number of years ago, but human chorionic gonadotropin was just made illegal for compounding pharmacists to make. So it is still available though by Big Pharma. So they didn't want me to talk about it because of that, but this happened in the office. I go to Naples, the Naples Center for Functional Medicine, 1 week a month. And in November and December, I'm probably going to be there for about 2 months. So I'm building up a practice there because we can do so much. We have a hyperbaric oxygen center. We're going to get a Heidelberg gastric analysis unit. We've got an IV room. We've got a lot of things that we can do over there. And I work with a team of medical doctors that are really phenomenal people. So what happened is one of the women that works there sent me her daughter a few months ago. And when I was there in the lunchroom, she told me this video that I'm going to share with you. So then I decided to go back through her granddaughter's chart and share with you the whole progress of how we reversed endometriosis and a lot of the symptoms of PCOS in 2 to 3 months quickly. So I decided this is where life's taking me, because in the lunchroom, Kate said, you gotta hear what's happening. So here's Kate, and let me know if you make sure you let me know if this is loud enough. I walked into the lunchroom today at the Naples Center for Functional Medicine, and Kate told me this.
I hadn't seen Dr. Berkson in a while, so I wanted to let her know about my granddaughter that she treated probably 3-4 months ago. And over the during COVID, she had come down from Orlando to spend some time with her grandpa and I, and she stayed in an apartment that we have, and we never saw her throughout the whole day. And then she would come up and have dinner with us. And one night at dinner, she said, I started crying today out loud, all by myself. And she said, because I am so grateful for the way I feel normal. I have no pain anymore. And she said, I'm so happy about my health, because she has struggled. She's 19 years old, and she has struggled for as long as she can remember with what is it that she has?
Endometriosis.
Yeah, endometriosis.
A number of things.
Yes.
She's a pretty miserable young woman.
She was, and whatever Dr. Berkson did, she is absolutely cured. So so I just wanted to let Dr. Berkson know that today.
So we're going to go on to the next.
I walked into the lunchroom
today. Let's talk about, she started in the clinic, and she came in with a lot of these symptoms. She's a lovely woman. She was 18 years old. I guess she's 19 or getting close to 20 now. And she was seeing one of the MDs, and she was referred by a pediatric gynecologic specialist. And she had ongoing issues with PCOS and IBS, the surgical intervention and removal of chocolate cysts identified. She had constipation most of her life, sometimes not going to the bathroom for 10 days. She had brain fog, depression. She was irregular menses, anxiety. She was on Zoloft, Singulair, Accutane. Her gynecologist had put her on 25 milligrams of progesterone at night, and it really wasn't doing much of anything. She was on Miralax, it wasn't doing anything, and she was on PPI. She's like, 18 years old, and she's on all these meds. And they had removed a cyst. She has also asthma. She had this rare little rash on her skin called molluscum. She had surgically diagnosed endometriosis, depression, anxiety, ADHD, a history of mono, seasonal allergies, IBS with a lot of gut pain that's sometimes debilitating. She had reflux, and she was feeling poorly ever since she started menstruating at 12. So for 6 years, as long as she could remember, she was a miserable kid that was isolating and really not having much to do with the world. And I just fell in love with her, but I didn't see her yet. So she's being seen by another doctor in the clinic. I'm just kind of running through her chart. So she had laparoscopic ablation of endometriosis in 2018, which really didn't stop her pain. On both her blood and her Dutch tests, her estrogen level was really low for an 18-year-old girl. Her progesterone was low, her vitamin D was low, her minerals were a little bit askew, her testosterone was a little bit high, and she had an MRI of her abdomen to rule out any masses, and everything looked good. She was tested for food sensitivities and moved off gluten and dairy. She was given a Trontiel, which is a bark herbal product that Kenneth Brown from Dallas that I've had on my radio show made, hoping that that would help her IBS pain. That's a great thing for gut pain. You take 2 twice a day, but it didn't really help her. She was identified with a parasite in 2015 and treated for that, but it didn't really help her. The doc was contemplating doing a GI map and following up, and took her off gluten and dairy, and he gave her a lot of magnesium, which didn't help her constipation at all. She had 10 days sometimes where she didn't go for 10 days. This doctor at the clinic put her on, she had elevated C-reactive protein. It was almost 4, should be under 1. So he put her on fish oil and he put her on some gut repair things, and she still wasn't getting better. So she had anxiety, depression, brain fog. He thought it was most likely from the estrogen deficiency, but wasn't quite comfy like we were just talking about with giving an 18-year-old girl yet estrogen. He changed the Singular to quercetin, and he thought the fatigue was due to high cortisol that was sitting and squatting or competitively inhibiting. Because if you have elevated stress hormones, elevated cortisol, it'll sit on all your other hormone receptors, even insulin, and block the ability of other hormones to get in, because cortisol is the big hormone bully. It's a hormone bully, so when you're stressed out, you bully your hormones. So he gave her cortisol manager, which of course is butcher's broom and magnolia blossom, to bring down the cortisol at night, and that didn't help. She has insomnia, even though he was bringing down her cortisol, he thought it was from cortisol. High at night didn't help. He gave her vitamin A for her acne, and he also, a little later on, also gave her the boron to see if he could boost her estrogen levels the natural way that some women, in fact, there's one study on menorrhagia where women had really very heavy periods, that's menorrhagia, and they gave them 100,000 units of vitamin A a day, and 80% of those women, their estrogen levels went up and their menorrhagia, the flow of their periods normalized. So high dose vitamin A, 50 to 100,000 units. She was a very tiny, thin girl, so he only gave 50,000 units to her. It didn't bring her estrogen up. It didn't work for her. She was low in D. She was a little off in her hormones, and he gave her some iodine because she had cysts. So that's one thinking, but it wasn't, that didn't help her endometrial pain at all. But in her follow-up, she looked a little bit better for a while, and then all of a sudden the pain would come back again, and the constipation never improved, even though the Atrontiel did get rid of the bloating. So Atrontiel gets rid of bloating, but I just had a patient, a very close friend of mine, in fact, that a naturopathic doctor gave her Atrontiel to treat her SIBO. So Atrontiel doesn't treat SIBO, it only treats bloating and pain. So I called up Kenneth Brown and said, does your product treat SIBO? He went, no. I called up Sam Rabar that we're going to have on talking about SIBO because he's the world's expert as a functional gastroenterologist, and he said no. But see, people are out there using things in different ways, and it isn't always accurate. But nonetheless, she would get better, but she would not get better. He gave her a little bit more progesterone. He kicked up the progesterone, the doc that was seeing her. He increased the A and the boron to try and increase the estrogen, and he gave her, because of her PCOS, chiroinositol, which is one of the classic interventions for PCOS to help reduce insulin resistance, but nothing helped. Just nothing. This is all good, sensible stuff to do, and she still was miserable. So now it's whoops, let me go back here a little bit. So he's been treating her now for 2 years. She's been coming in and out. He's been doing all this stuff, getting rid of dairy, getting rid of gluten, doing each thing, and nothing's really working. So I was about to enter the scene, but he ran some labs right before he said, send her out to Dr. Berkson. And her TSH was, I don't like it to be above 1.98. I learned that from Dr. Jerome Block, who I worked with in Tulsa. and was in practice 55 years before he died. She had TSH of 2.24, then 2.27 before that, then 3.0. So it hovered between 2 to 3, which says to me that thyroid's probably part of her transit time issue. But they were uncomfortable to give her thyroid. She's 18 years old. They were uncomfortable to go into hormones, but we're going to talk about what we did in a few minutes. Her RBC was 5.1. He thought it was good. I like to see RBCs all in the 6s. If they're not in the 6s, I push more of the magnesium. Her hemoglobin A1C, whoops, I left out the H, sorry, was 6.2. She had a lot of insulin resistance from her PCOS. Her estrogen was further low. The boron and vitamin A did not work for her. Her progesterone was low, even giving her progesterone. Her homocysteine for a young girl was a little bit high. It was a 10. And here's her C-reactive protein. It was at 3.27. So then they, let's see, she had breast tenderness from the progesterone because he gave her so much progesterone, hoping that that would clear things up, and it made her breasts hurt. And she was back to a lot of pain and very few bowel movements. So then I'm trying to move where I see myself here. Okay, so then she saw me February 1st of this year for the first time. And she'd already been at the clinic for almost 2 years. And she said she's had everything started at puberty, anxiety. She had a hard time walking because she had these small needle-like spasms in her feet. So this is my own intake and some of the things that I noticed on her. She has not noticed anything that makes that needle-like spasm better. Not she had vaginal itching, which her gynecologist took a look at and said she looked normal. So I recommended Lactobacillus reuteri. And as you're going to see, we got rid of it, but she never went on the reuteri. So it was a totally different thing that we got rid of it, because I recommended it, but she never went on it. She was on Lexapro now instead of Zoloft. She was chronically low in iron. That's because she didn't have any stomach acid. The two things you look at really slow transit time are borderline subclinical hypothyroid and not enough sufficiency of hydrochloric acid. And when someone's been ill for 6 years, she's like 18 or 19, but she's been ill, pain, feet, spasm. She's on a litany of meds. She's stressed out. The highest mitochondrial demand in your body are your parietal cells. And wherever nature prioritizes a cell, it has the most mitochondria, because mitochondria make energy, plus they oversee a lot of other things. Their job description is expanding. You have more mitochondria per cell volume in your parietal cells that make stomach acid than you do in your brain or your heart. The second place that has the next level of the most mitochondria per cell is your hippocampus, because that's your physiologic soul. And then the third place is your heart. Your heart is below your brain and below your parietal cells. So stomach acid is supreme in the world of making everything else work. It's the number one domino that tells your pancreas, get ready to secrete all your lipases and your different pancreatic enzymes into the gut. It tells the gallbladder to be ready to contract to release bile. It's the number one domino, and it gets rid of all pathogens that come in on food, and it reduces minerals to their electrical, biologic, bioavailable state. So whenever someone comes in with chronically low iron, you want to think, okay, can they be insufficient in stomach acid? And also, can they be insufficient in thyroid? Because thyroid and iron are very intimately bound too. And she always had a lot of dizziness on standing. We ruled out dysautonomia, but that was really because she was so thin, her blood pressure was so low, and she just wasn't absorbing anything. And she had inflammation in her body with a hemoglobin A1C of 6.2 and a C-reactive protein. But this is kind of what I was seeing when she saw me. She had dysmenorrhea, menorrhagia. She was feeling transgender, diagnosed with Asperger's, depressed for months, if not a year. Ablation helped a little bit back in 2018, but everything has come back, and she feels worse after she eats. That's another flashing red light of stomach acid. This tendency to constipation for years, ever since she started puberty, because her hormones have been off since puberty. And what we teach at A4M is that hormonal imbalance is perceived and experienced by the body as a stressor. So going into menopause is a stressor. Insufficient hormones is a stressor, but she had insufficient hormones at menarche, and it was a stressor. That's one of the reasons Her parietal cells weren't making enough stomach acid, and her TSH, remember, is hanging out between 2 and 3, and her free T3, which I don't have on here, sorry about that, was like 2.1, 2.2. It's a very narrow range, but we like to see free T3 ideally be between 3.5 and 4.5 if you've got someone with symptoms. Because if you take free T3 all throughout the month, it goes up and down and up and down. It's a little bit cyclic, but there'll be a trend. And it's more important to improve its level if someone has symptoms. But Medscape over the last three years has now published many articles saying, hey, let's get real. TSH and even T4 and T3 really don't tell us what's going on in peripheral tissues. I mean, let's call a spade a spade. This is Medscape that goes out to 6 million medical providers online. And let's see, am I doing okay? It's 12:45, we're doing okay. And they said, there's a lot going on in peripheral tissues that TSH and free T3 and free T4, even free T3 and free T4 don't tell us. So they were saying in that article, which there were several like this, if you have a woman that's infertile and she's done everything you can do and her thyroid's perfect, just give her some thyroid anyway, because you don't know if the thyroid that you're judging her thyroid status by is really telling you what's happening in peripheral tissues. So I'm more bold about giving thyroid at, because a lot of labs say you're not hypothyroid unless your TSH is over 5. Well, I'm not seeing that in my life at all. She has a phobia with outside bathrooms. She's tried stomach acid, but it gave her nausea and heartburn. So we didn't want to jump to that on her, but we were thinking about it. But she said she tried it and she had a terrible response, but she sees undigested food in her stool. So most likely for her, it's her thyroid, because she tried stomach acid. Thyroid receptors are all through the gut. It oversees transit time. So I'm looking at the thyroid. So this is what I said to Dr. Maristani. I want you to consider a small dose of estriol topically to help with the constipation, because there's estrogen receptors in the gut, and also the needles in her feet, sensory sensations, and use some oxytocin because she doesn't feel all that well a lot. She has depression, she has anxiety. Oxytocin is anti-anxiolytic and it makes you feel better in your body. And oxytocin receptors are all throughout the gut that help your estrogen work better in the gut. So I said, well, can we consider a mix of oxytocin and estriol? And I gave her 2 pancreatic enzymes before meals, which no one had done, I don't know, but she didn't do well with stomach acid. And I used raw green banana starch because it's a resistant starch that kind of feeds short chain fatty acids to the enterocytes. And I asked her to try another source of magnesium, which we never got to. And I recommended the Lactobacillus reuteri for the vaginal itching, which she never got. And my big recommend for endometriosis was, let me go back here again. My big recommend for endometriosis was a paper that I'd been reading, a randomized trial that I'm going to share with you in just a little bit, of giving human chorionic gonadotropin 14,000 IUs sub-Q in the abdomen twice a week for 3 months. And so what he did, because that's my recommendation, he's her patient, and what he did was he gave her 1,000 international units of sub-Q HCG. Now, I'd run the weight loss program at the Wiseman Family Practice Center here in Austin for 3-4 years, where we gave HCG. And we noticed in many patients that it would normalize their hormones without even giving hormones. Sometimes it would normalize thyroid. Sometimes it would normalize someone with endometriosis. It was a shocker. And that's where I first bumped into this. And then I did sleuth in the literature. And lo and behold, there were randomized trials of other people thinking of giving HCG, because a lot of times endometriosis goes into remission in pregnancy when you have a lot of, HCG is a pregnancy hormone. He gave her 0.5 milligram of estriol, which, God bless him, he added with a little oxytocin topically. And he gave her 25 micrograms, a little dash of T4 and a dash of T3. He'd already given her iodine, which we sometimes first do to see if you just don't have enough iodine to make your molecules, because T4 and T3 are made up of iodine. And then instead of doing all that stuff with cycling the progesterone with 4 different levels that he'd been doing, we came down to 2. Let's give her 15 milligrams cycled with 150. So she's on progesterone the whole month, because progesterone resistance is also linked to endometriosis. And the way you treat progesterone resistance is giving more of it. But you cycle it to mimic more of Mother Nature. And we gave it in a base of VersaBase, although knowing what I know now, a month later, I discovered that there's a brand new base, which we talked about last month, called VersaHydrospace, that's even more absorbable. So if I would have suggested this, this protocol with Maristani now, I would recommend it be in Hydrous, HYDROUS base. So within 1 month, in her blood and in her Dutch test, all of her hormones normalized just by being on the HCG. Well, and she was on a little teeny bit of estriol. She had normal energy. She needed less sleep. The needles in her feet that had been there since puberty were gone. Her abdominal pain was gone. And she was having 2 bowel movements a day regularly. She still is. She's called me now and thanked me and written me letters. And she just feels like she has her life back. Her vaginal itching is gone, but she didn't go on the Lactobacillus reuteri. Her depression is gone. She's off all her medications within 2-month period. She's off all her medications and she's feeling incredible. So this is, her hemoglobin A1C went down to 5.3, her CRP went down to 1, her TSH was 0.98 by 420. Everything cleared up. I want to go, because I want to get into some questions, so I'm going to go down here. Here's one of the studies on HCG and endometriosis. They did 31 patients. They gave 1,500 to 5,000 IUs of HCG per week for a period of 3 to 12 months. They basically found you only needed to give 3 months and longer wasn't better. And they found that there was a highly significant reduction of endometriosis related pain and even of implants. There's some rodent studies where they theorize it's HCG is down regulating leptin expression, and you can read these on your own. Here's another about the theory of mechanism, but HCG administration reversed leptin upregulation in endometriotic tissues. So in rodent studies and one randomized human trial study. So I had a patient that a nurse practitioner that took a class with me said it was her best friend. Would I see her? It was the end of the day. I was going on a vacation the next day, and we just spent hours on the phone. She was 32, and she had such bad endometriosis. She was set up to get a complete hysterectomy the next week. She wanted children, but she tried, couldn't have children. So what we did was we put her on HCG and a dash of estriol, and we also optimized her thyroid, and she was on it for a 3-month protocol, and 5 months later she got pregnant and she never needed to have the hysterectomy. I only have a few patients that I've done this with because there's only so many people that will even do this. And a few months ago, compounding pharmacists can't get it compounded, but it's still available as a big pharma med. It's still out there to be used. But look at this. It's crazy that women go through all these surgeries and infertility and everything when this is available. And then I also, here's another study on the mechanisms of why this might be happening. I didn't put her on melatonin, but there's a randomized trial using melatonin on this. And here's looking at 40 women, 18 to 45, and they gave them 10 milligrams of melatonin for 8 weeks, and they reduced their pain incredibly. So there's a number of studies. Here's an oophorectomized rats. And here's some more studies on melatonin. And then there's a double-blind placebo-controlled study on gluten. But you know, this young woman had already been off gluten. A lot of times you'll see these studies and a patient's come into you and done all this and it didn't work for them. So you have to find what is the optimal thing. And once you find the optimal thing, it's like all the planets click into place and align and people get better really quick. My experience is with very ill people for years and years, and they're my favorite patients, and certainly I don't heal everybody, but if you get what that pivotal keystone issue was that was not addressed before, and you give it not just a litany of 40 supplements, but you hone in on what that, you know, who killed Mrs. White in the library with a lead pipe, that missing clue, then everything just falls into place. Click, 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 click. The planets align and the patient gets well pretty quickly if you've hit the nail on the head. So here's the articles on gluten, and there's also how celiac patients have a much higher incidence of endometriosis in this one study. I thought that was interesting, and so I gave you all of that, and I want to stop so that we can have some questions here. But I like when something happens in life, like I got stopped in the lunchroom by Kate, who was the grandmother of this young woman. And she said, I just got to tell you. And then I thought, this is something I should certainly share, because look how dynamic this is. So and please, you can see if you send in a question, I'll answer it, but it might also take us down a whole nother pathway that gives us a lot more information. Like, did you know that sleep apnea elevates your stress hormones, which squat on your estrogen and make estrogen insufficiency at local tissue levels, which then predispose the liver to fatty liver progression? And did you know that women on tamoxifen should have transforming growth factor beta and galectin-3 monitored? So this came from these questions that two ladies sent, two doctors, and I'm really happy about it. Does calcium deglucarate elevate calcium? No, it's really not a form of calcium. It's really the deglucarate that you're taking it for. And the main reason I give calcium deglucarate is if somebody has really high beta-glucuronidase in their GI map stool, and that shows us that they're not processing their estrogen well, and they have some dysbiosis. And usually we give about 1,000 milligrams 2 to 3 times a day, depending on the woman's size, how bad her symptoms are. But if a woman is very large and she's taking 1,000 to 4,000 milligrams of deglucarate a day, she is getting some calcium, and you certainly won't want her to give her any more. You know, all the studies clearly say, I wrote about this in Safe Hormones, Smart Women, that if you get over about 500 milligrams of calcium a day, you start getting more poor bone, and more risk of fractures. And why doctors are out there and endocrinologists and saying you should take 1,200 milligrams, 1,500 milligrams. The only time you need high dose calcium for a short while is after you get an adenoma removed in a primary hyperparathyroidism surgery. And for a while, your calcium's all askew because parathyroids have everything to do with your calcium levels. But most of the time in Tulsa, we remineralized bones, women who had osteoporosis in their 70s, 80s, and 90s, and got them back to bone integrity, and never gave them calcium. Gave them lots of other minerals, optimized their digestion, optimized their hormones. But calcium above 500 milligrams starts giving you poorer bone than better bone. So if you do need to take some calcium deglucarate, great question, Maureen, for a while, and depending on your level of beta-glucuronidase in the GI map, et cetera, and your body size, you want to make sure you're not getting calcium in your supplements in other areas. And you want to make sure that you're not eating, you don't have to worry about vegetables and this and that, but you wouldn't want to go after a lot of dairy products with a lot of calcium, because calcium is not what we thought it was. It is not the bone protector. Estrogen is the bone protector, but it only protects bones if oxytocin is available. In my new book that I haven't finished yet, my oxytocin book, I have a whole chapter on how all the actions, or many of the actions, not all, that we credited with estrogen, you know, like being a colorectal protector, because women have less colorectal disease in premenopause, and then of course they have worse after menopause, and women have better bones before menopause and worse bones after. It's the oxytocin that enables, the oxytocin is the hormonal enabler, like a psychological enabler. The two of them are a dyad, and their receptors overlap on each other. And it's very, very interesting. So our understanding of hormones, it's all about the interweaving of them. They're just not a separate deal. And that's why sometimes you can replace a hormone in a woman that she really needs on a test. You'll see her hormone is really low, and she takes it, she doesn't feel anything, or she feels worse. And that's because there's some other hormonal problem in the other bigger, larger hormonal family that's intertwined and really creating some of the noxious environment that's not allowing just the simple fix of taking more of a hormone that appears to be low and getting a response. So hormones, again, are this tapestry. Let's see, great information. Thank you so much. And we're almost at the time, but there's let's turn all the mics on and have a few minutes of chit-chatting and see what people say, ask, talk before we say adieu. So what'd you think? Was that good?
Awesome.
Okay.
Very helpful.
Any questions?
I do, in prep for another time, do you work with folks with interstitial cystitis?
Oh yeah, boy, that is tough. that is one, you know, there's some diseases that are really, really tough.
Mhm.
But I think that interstitial cystitis, and you know, there's subtypes of interstitial cystitis, but I think hormones have a lot to do with it. I think I think they're really hormonal patients that haven't been treated in that way.
And she
Because you
can't
have a
get
lot of,
pregnant. She can't get pregnant. She's a police officer, so she has a lot of stress, as you can imagine. And yeah.
right, you deal with first responders, right?
Right.
That's your specialty.
Mhm.
Yeah.
Mhm.
By the way, you look really pretty today, Maureen. You look very lovely
Thank you.
today.
Thank you.
Well, yeah, so anyway, the answer to that is
Okay.
yes. Okay. Are there any other questions on here before we say adieu? Or, you know, please send me some questions for next month, because you can see the deep dive. Someone sent a few questions and we went into 15 minutes. It was pretty enlightening for all of us, because I love to deep dive in this peer review science. Is there anything else here? I don't think so. We have a small group. I think most of the people are going to be listening to this when they have a chance outside hours of work. Okay.
Did you want to talk about Tuesday?
Oh, thank you, Sarah. So it seems when I lecture and we're talking on gastroenterology and all these cool things, and the main thing that people surround me at the breaks and want to know about, they go, oh my God, you're so old and you look so young. Holy shit. That's what they always say. They like use the S word. So what do you do? And then they'll take out their phone and they go, no, I just don't want to know kind of what you do. I want to know everything you eat, everything you take. No, I mean like everything, because I want to look like you when I'm that old. So I thought I would do, not that I'm that whatever, but there are some things that I've learned to do. It's not a lot. I don't even know if we need a whole hour for it. But there are regular things that I do that have made a difference. So I thought I would share them so we could all, besides getting smart plus heart, we could get more beautiful together. So that's next Tuesday at lunchtime, and it will also be archived. It's for every level. It's a gift, and that's what I'm going to do off and on, is just give talks and gifts and things for everybody, or sometimes for, I'm going to talk next week on in the live middle layer of the membership on how to take supplements accurately and how to read labels. Yeah. So that's going to be the third Thursday of next month. And if you have, I think we mentioned something, I said sometime during this talk we should maybe do a deep dive on that. Does anyone remember what that was? It was something I just said maybe we should do a deep dive on that. So I remember now. If you want me to do a talk on molecules of mass destruction, that's what we were talking about, because I said, who knew that if a woman is on tamoxifen, you really want to know where her two main cytokines that drive fibrosis, where their levels are at. Now why don't oncologists know this? I mean, that just seems so appropriate to know. But then there are all these molecules that drive a lot of disease, and they help us figure out how someone should eat. And because you hear about this nutrient and you want to take it, you hear about another nutrient and you want to take it, and before you know, you're on 30 to 40 nutrients. And is it even healthy for your kidney and your liver to take that many nutrients? And are you really doing yourself a service or not? So you want to hone in on what your body needs the most. So I'm also going to, in that talk on supplements, talk a little bit on my sixth sense that I've developed with working with people of how to figure out to prioritize supplements. But if you want me to speak on molecules of mass destruction, let me know. I do have a radio show, a podcast on two of them called Biohacking: Molecules of Mass Destruction, and it's on TMAO, trimethylamine N oxide, and galectin-3. So that's out there, but there's disymmetric methylarginine, asymmetric methylarginine, cystatin C, and we were just talking about transforming growth factor beta 1, etc. So let me know if you want to chit chat. Yes, please do the supplement review. Yes, do the molecules of mass destruction. Just tested hers. I had a woman that just came into me yesterday that was really worried about her kidneys because she had a lot of flank pain, and she had a few episodes of blood in her urine, but no one could ever figure out. She had a CT scan and it was normal. And she had already gone ahead, because of listening to my radio shows, and run her TMAO, which was one of the most perfect levels I've ever seen, run her galactin-3, run her cystatin C. And the bottom line was, she didn't have really kidney issues. She had something totally different going on. She didn't have what she thought she had. But we were able to hone in and really know that, because she'd gone ahead based on listening to the show and running all the right molecules. So it was very cool. On the very first talk we had, she had them all done and all put in a spreadsheet. And we were able to show where the issue was, but it wasn't where she had thought that it was. Let's see. Oh, Sarah already put that in there. Good for you, Sarah. Thank you. Look at how beautiful Sarah looks today. Look at her hair. She's like Lady Godiva, or Rapunzel. She looks so great. Well, I guess we're done for today. And I look forward to next month. Plus, I'll see you next week, if you like, on some of the hints of how we can slow down the aging train, and like looking in the mirror more and more. Be well, everybody, in these chaotic, unprecedented. Bye-bye.